everyone. Is my screen shared? There we go. So welcome, and I'm glad to be here this morning. We've got a topic that hopefully is, it's pretty timely. So hopefully, we'll be able to help give you some practical tools towards the end. But this question that always comes up of whether we should, with all of the attention on alternative police responses, better mental health responses, this question always comes up of, well, should the police go, or should these specialized teams go, or co-responders go? And so we're going to dig into some of the different models. And with us today, there's so myself. I work for an organization called Connections Health Solutions out in Arizona. We run crisis centers, and I'm a psychiatrist with that organization. We've got Dr. Matt Goldman, who's also a psychiatrist, who is the medical director for the crisis system out in San Francisco. We've got Aisha Delaney, and I never say your last name right, Rumsey, who is with the Council of State Governments Justice Center. She's the director of behavioral health there. And then Sergeant Jason Winsky, who is over the mental health programs at the Tucson Police Department. And I'm going to go through the intro pretty quick because got a lot of slides. We want to try to get to some questions at the end. But, currently our systems are broken in this area. And you probably all know this since you're at this conference, but, there's the increasing suicides and overdose deaths. There's just not enough capacity for mental health people, the criminal justice involvement, emergency boarding. And at the heart of all of that is there's also, as been brought to people's attention, more so recently, a whole lot of disparities. A recent study looking at the suicides for the pandemic, during the pandemic, actually showed that they went down for whites and up for African Americans. So there's clearly a lot going on here. And it kind of starts off with, if you ask for help with you have a behavioral health issue, there's already these like two alternative pathways. If you have chest pain or a stroke or something like that, you call 911 and you get an ambulance, and a trained person takes you to the hospital for you to get care. If you call because you're having a mental health emergency, like say you're suicidal, when you call, you get law enforcement. And so that immediately sets up the situation for potentially really bad outcomes. A quarter of officer involved shootings are thought to involve mental illness. Half of these occur as they're responding to the person in their own home. And then if you factor in the race and mental illness, the risk is 10 times of being killed by police in one of these encounters. If we encourage police to bring people to the emergency rooms, but most ERs don't have any psychiatric capability, and the patients wait for hours, sometimes even days, waiting to be transferred somewhere else to get care. And oftentimes they ask the officers to wait with them. And police are busy and they have crimes to fight. And even if they're well-meaning, the competing demands of that makes jail the path of least resistance, because it's just so much easier to take the person there. And there's this sort of myth that people will get the treatment that they need in jail, and they really don't. What they end up getting is incarcerated twice as long, more likely to be assaulted, put into solitary. They get their Medicaid turned off. They've lost their job. They've lost their housing. The sentencing, there's bias there, especially if there's substances involved in the different sentencing for that. And so, not surprisingly, the prevalence of mental illness in jail is 3 to 4 times out of the general population, and has led some to call them our new asylums. So what we have is this situation where it's kind of easier to get into heaven than to get into psychiatric care. And it shouldn't be that way. A behavioral health crisis, it's a potentially fatal health emergency, just like a heart attack or a stroke. And it requires the same systemic response with the same quality and consistency that we expect for these other medical emergencies. And police know, they have recognized this for a long time. Kind of the sort of standard now for police agencies, this crisis intervention team model, which began in the 80s in response to a police shooting of an African-American man with mental illness. And the centerpiece is the 40-hour training that helps officers recognize, respond to people with mental health crisis. Involves, I mean, I'm sure many people here are familiar with that, with the de-escalation, the role playing, involving the community. And it's the research shows that it does help. It helps with officers being more likely to bring people to treatment, to not have uses of force and things like that. But in the little dark box here, I wanted to highlight that everyone, when people think CIT, they immediately think of the training, but it's really meant to be a comprehensive community approach that not only is the officer component of the training, but the community needs to have a crisis system that can receive these individuals from the police in a way that's quick and easy for them to do. And so that's what we're going to be talking about here. More recently, to address the criminal justice issue and the overrepresentation of people with mental illness in the justice system, there's another framework is called the Sequential Intercept model, which basically says there's a pathway you follow through the justice system, from being arrested to booked to your initial appearance and so forth, and that at each part of that path, there's an opportunity for the mental health system to intercept that person and keep them from going further, or at least make it less bad if they do. And so crisis is here in this. Intercept 1 was law enforcement, working with law enforcement, and then it's since been recognized even before that, having a crisis system that that doesn't even that circumvents even needing to use the police in the first place is this even earlier Intercept 0. And so these services that we'll be talking about today live in these Intercept 0 and 1. And especially now with all the attention on having different responses and better responses for involving police, there's been a lot of focus on all these different programs and services. And you look at the news and someone's always highlighting, in this community they have this team, and then there's the Hoots team, and there's all these different things. And so it's hard to make sense of it. And what we find is that it's more than just having cool services and programs and little pilot programs and this and that. You need various services, but then they need to work together as a system so that they're coordinated, and even if it's different agencies and programs that are operating all these cool services, that they're working together towards common goals. And then that way you get a whole that's more than the sum of the parts. Another way of looking at it is, if you think about crisis, crisis is an example of where the clinical goals, which is having people taken care of and getting their needs met in the least restrictive setting, meaning the most community-based setting. So, home instead of the hospital when possible. That's also, if you're a funder, it's the least costly to have people be taken care of out in community-based care. So those goals are pretty closely aligned. And if you look at the different services and you have a continuum along this least restrictive, least costly continuum, then you basically are at every level having the services working towards those common goals. So out in the community, if you're this data is from the Southern Arizona crisis system. Crisis line there gets about 10,000 calls a month. They're able to resolve 80% of those by doing a telephone counseling or being able to make appointments for people and things like that. For crises that can't be resolved on the phone, they can dispatch mobile teams. So they have centralized dispatch, but they could dispatch multiple teams all throughout the area 24/7 that cover that area. And so if the mobile teams, 2 clinicians, do a face-to-face evaluation, then about 70% of the time they can resolve that crisis in the person's home or wherever they are without having to take them anywhere. If the person's too acute for that, there's various crisis facilities, which we'll all talk about these services in detail. But these crisis facilities are places that aren't hospitals, but they can accept people in mental health crisis and keep them overnight, and through really working on resolving their crisis and working with the community, about 60 to 70% of those folks can be discharged back to the community without having to go to the hospital. And then there's post-crisis wraparound services to help keep people stable. At every point along this continuum, there's easy access for law enforcement built in. So 911, for example, co-locating crisis line staff with 911 to make it easier to intercept those calls. The mobile teams, they have in their contracts, it says you have to respond within an hour to a call in the community. But if the police call you, you have to respond in half an hour. So there's things to incentivize easy access for law enforcement, and also co-responder teams and collaborative teams like that. And then the crisis facilities, as we'll talk about a little bit later, are really set up to be easier to use than jail. So that the crisis center becomes the path of least resistance instead of the jail. So you put all that together and you potentially have a system that can decrease the use of jail, emergency rooms, and inpatient hospitals for people who were in behavioral health crisis. And now I'm going to hand it over to Matt, who's going to give us some more details on call centers.
Great. Thank you so much, Margie. Great intro for us. I love that slide that you just showed. I always refer to it as the Mona Lisa of crisis slides. It just captures everything so beautifully and really sort of depicts what that system could look like. I'm going to take us through kind of piece by piece some of the components of that overall system that Margie described, and walk through some of the evidence that that has supported the implementation of those types of programs. So if we could go to the next slide. So starting with crisis call centers. There's a lot of different versions of crisis call centers. The ones that have been studied most are the ones that are affiliated with the National Suicide Prevention Lifeline. That's 1-800-273-TALK. You often see that number like at the end of a news article about some sort of mental health related event. And that's a line that's available nationally, which when they did some early studies of it back around when it was implemented in the 2005, 2006 type period, they did some really rigorous analysis and found that actually the call line itself significantly decreased suicidality during calls. A third to a half of callers were successfully connected to mental health referrals. There was a special training called Assist that decreased depression and suicidality after the call. And these National Suicide Prevention Lifeline crisis call centers also implemented a follow-up initiative that was able to stop about 80% of individuals from killing themselves and about 90%, kept about 90% safe. So these call lines can be very effective. Next slide. That said, there's big changes ahead for crisis call centers. So I'm sure many of you are familiar with this, this transition to 988. So if you look at this graphic on the right side here, that National Suicide Prevention Lifeline call center footprint that I described, it's only about 3 million calls annually. There's 13 more million calls that are handled by local, county, and state crisis lines outside of that National Suicide Prevention Lifeline network. And there's an additional 24 million or so calls, which is about 10% of all 911 calls that are mental health related. And so when you add those all together, we're looking at like 40 million annual crisis calls, which is over 10 times what the National Suicide Prevention Lifeline is getting. That said, in July of 2022, that Suicide Prevention Lifeline is going to transition its number so that in addition to being able to call 1-800-273-TALK, you'll also be able to dial 988 from any telephone in the United States and be able to get to the National Suicide Prevention Lifeline. And so they're going to start getting a huge increase in call volume. The types of callers that they're going to be getting are going to be different. They'll get more of those kind of bystander calls like what 911 would usually get. Ideally, there will be arrangements where 911 will be able to divert calls to 988. There ideally would be a capacity for 988 to dispatch mobile directly. Also, even there's a possibility for 988 type centers to be monitoring and maintaining bed registries and facilitating referrals, and important to what Margie was saying about post-crisis wraparound services, being able to facilitate those types of connections as well. So call centers are at a major time of transition. It's an exciting time, but there's a lot of changes ahead. Next slide. So related to that, so mobile crisis also has some evidence for it. And ideally, mobile crisis would be dispatched by a 988 or a crisis call center. Oftentimes, that's not the case. There's many different models of mobile crisis, including teams that are dispatched themselves, by themselves, dispatched by other type entities, even dispatched directly by 911. So on to the next slide, we'll see, there's a lot of different versions of how these are configured. So mobile crisis was first established as early as the 1930s in Amsterdam. In the US, many mobile teams have been sort of expansions of CIT programs, which, as Margie described, really took off in the 1980s. There's a lot of different compositions. Usually it's 1 to 2 clinicians, most often a behavioral health clinician, plus minus, somebody like a psychiatric technician or some sort of other mental health staff. There's the Cahoots model, which has gotten a lot of press and a lot of national attention, where they pair a behavioral health clinician with an EMT. Also paramedics are sometimes corresponding. And then some programs also include peers. So people with lived experience of mental illness on their actual mobile crisis response team, including one in San Francisco that we recently implemented, which can add a lot of value to the team in terms of engaging folks. So as of June 2020, at least 34 states in the United States had mobile crisis teams, although few operate statewide. And again, there's a lot of variability in those models. Next slide. Some of those, so corresponders and police-based teams is also, certainly a model that's seen. So corresponders may ride together or meet at a scene if we've got, for example, a behavioral health clinician or a peer pairing up with an officer. The clinician could be employed by the police or by another agency with some sort of collaborative agreements in place. That's also a common model. There are some dedicated police mental health teams. So this is often in collaboration with CIT programs, but kind of a step above, where a team might focus solely on mental health. And I think Jason Winsky is gonna speak to that type of model a bit more as well, where there's really an expansion of their purview. So doing things like duty to warn and handling more complex mental health type cases that include real significant history of violence or presence of weapons. And examples of functions that they might do together, so responding to mental health crisis calls, following up or case management after a crisis, working on substance use and connecting people to treatment instead of arrest, proactively investigating and identifying and connecting high-risk individuals to treatment before they reach that point of crisis, and then also outreach to vulnerable populations, including especially homeless populations. Next slide. So there is some good evidence for mobile crisis. There have been some single site studies that have focused on post-crisis service utilization and community engagement. I'm not going to go through all these details. You'll be able to review these slides later, I think. But generally to say, the studies that have been done, they tend to be kind of retrospective. So looking at past data, they're not true experimental, randomized control trials. They're more what we call quasi-experimental designs, where they're kind of looking at past data and looking at differences in outcomes between those who received the mobile crisis services and those who didn't. But in general, they find things like after a crisis, there's less utilization of inpatient type services, there's cost savings, there's, and then even there's some mobile crisis services that are specifically for post-emergency department linkage or other like post-crisis linkage that also find good results, like improving contact to and referral to outpatient care. And that savings, Margie included that on her Mona Lisa slide. That is really important too, that as we get to those less restrictive kind of settings, those are also the cheaper settings. It's a lot less expensive to pay for a phone call or even for a mobile team than it is to pay for a full crisis visit in an in-person facility. Next slide. And so here, this is just an example of studying the implementation of a mobile team. And so in San Francisco, we're doing what's called interrupted time series analysis, which is basically like a fancy pre and post study of the implementation of this new street crisis response team. This is a team that is comprised of a behavioral health clinician, a paramedic, and a peer. And they ride in that nice red sort of para-ambulance fire department rig. We've got currently 2 teams that are expanding our program rapidly to have a citywide availability. And we're going to look at things post-crisis episode for the clients who are receiving services like outpatient mental health or substance use service utilization, acute utilization of, of services like emergency department or psych emergency. We're also going to look at connection to housing and other long-term housing placement, and then also jail entry. And so this is just an example of, really, it's an implementation science type approach to evaluation that can give us a really robust assessment and evaluation of a program, but even takes it a step further to really look at effectiveness of a program like this as we're implementing it into a real world environment. So really excited for the results of that. That's supported by the Robert Wood Johnson Foundation, and hopefully we'll have results by late next year. On to the next slide. So I'll hand this back to Margie.
So I'm going to be talking about crisis facilities, and there are, I mentioned that CIT says that it's not just training, it's a community response. And one of the most important things for that community response is a place to bring people. It's great to have all the phones and the mobile teams, but then there's people that need to be taken somewhere. And the CIT report, or the original white papers and research and writing on it, actually spelled out what does a mental health receiving facility need to look like. And it kind of have these 6 things where it's a single point of entry, that's you have access 24/7. But really the 2 that are highlighted are the 2 that are really, when we look around the country and we work with other crisis centers in other states, these are the 2 that are hardest to do well. The no clinical barriers to care and the minimal law enforcement turnaround time. What that means is, so what does that mean, no clinical barriers to care? It means that the crisis center should be easier to use than jail, so that it becomes the path of least resistance for the officers. And that involves treating the officer as a preferred customer, just like our patients are our customer. And what officers want, Jason can tell you, they want to get in and out really quick. So drop off time should be less than 10 minutes. They don't want to be turned away and sent on a wild goose chase because they've taken you to, quote, the wrong place. So that means you need to take everyone. You'll hear of places that only want to take low acuity, voluntary, not too violent, not too sick people. And there are people like that, also need crisis facilities that they can go to. But the highest acuity person, the agitated, the violent person, if those people are turned away, they still end up in emergency rooms and they end up in jail. And then people go, why do we build this fancy crisis center and we still have this problem of all these mentally ill people in jail? So you want a center that can take and care for these highly acute patients. And studies, there are emerging studies on this model showing that having there's some studies looking at CIT trained officers, and having a place where they can quickly drop off is critical for them using their CIT skills to divert the person to treatment. These centers can reduce that emergency room boarding we were talking about earlier, where people are waiting for hours and hours in the emergency rooms. And because people are getting their crisis resolved, it reduces the rates of people having to go to inpatient hospitalization. There are many flavors of crisis stabilization. There's currently no national standard for crisis services. So what you call a CSU, like crisis stabilization unit, in one state is going to be different than what someone in another state thinks of when they hear the word CSU. But the kind of broadly, kind of the different models is there's a 23-hour observation unit, which is really, so we tend to operate a lot of in Arizona, where I am, where there's a lot of short-term overnight observation that is able to take those highly acute folks. And we can do medically supervised detox as well. And basically take everybody. These units are locked, they can take police drops, and all of these units can have a recovery orientation and use peers. Living rooms, those are also kind of a short-term unit that is usually more geared towards the less acute folks, usually unlocked. Arizona's a little different in that the living room there still can do some of this higher acuity, but usually they're taking voluntary type folks. Sobering centers and social detox, these are places where police can drop off people who have substance use issues, but they don't have the medical oversight as, say, like a 23-hour obs unit would have, where they're not giving medications for detox. They're kind of letting people sober up, and then you're trying to engage with them and letting them go. And then crisis residential is kind of in usually days or maybe a couple of weeks of crisis stabilization in a residential setting. So not a hospital setting with 24/7 nurses, but a place where people can stay for a few days and get some counseling and peer support and things like that. And Matt's going to talk about crisis wrap real quick.
Yeah, to the next slide. So just briefly on this, so most emergency docs, so thinking about the ED setting, do not have a systematic approach to identifying people who are in psych emergency, who have high recidivism, so who frequently come to the ED. And that's just one of many problems in terms of really securing consistent follow-up for people who are in mental health crisis. And so what's really important is to develop some sort of post-crisis wraparound service. This is something that Margie's system in Arizona does really well. The ideal is to link people to long-term treatment, avoid reutilization of crisis and other services. You want to prevent future encounters with law enforcement whenever possible. So really thinking of this in that sequential intercept type approach, where it's diversion from law enforcement settings. And then also addressing social determinants of health. So integrating services like housing, transportation, food, other type employment and education programs in order to help support people and help them emerge from their crisis in a helpful way so that it's less likely that they'll return. This can be provided by a range of different agencies. It could be from behavioral health programs, including with peer navigators. Some law enforcement-based case management is out there, and then also community paramedicine, where the paramedics are playing a little more of an active role in that type of post-crisis service. Next slide. There is evidence, again, to support some of these programs. So structured telephone follow-up and monitoring has been well received by patients. Even postcards have actually been shown to help reduce suicide attempts, especially among individual repeaters of people, except for individual repeaters. That was one population where that wasn't effective. But for many folks, so a phone call after a crisis episode, a postcard, having a transitional clinic to increase attendance in aftercare can lengthen, the length of time that somebody's actually staying in the community as opposed to re-entering into a more acute setting. Even simple interventions like scheduling outpatient appointments prior to discharge and doing in-house case management. And then also repeat follow-up contacts also appears to reduce suicidal behavior. So there's a lot of ideas for this, but there's a lot more research that's also needed in post-crisis wrap.
Okay, so to answer our question, what we had at the beginning, is it cops, clinicians, or both? And the answer is yes. So this kind of sums up what we just talked about. So it has that kind of crisis schematic, and then you can see some of these programs then that can facilitate that law enforcement collaborative piece. And an example in action, as I mentioned, out here in Arizona, Tucson in particular, really has a lot of these features and is increasingly being looked at yeah, as a potential model. And so this is kind of an example of how you can use this framework to map what you have. And out here in Tucson, so we have the crisis line. We have the crisis line staff co-located in 911 so that they can try to intercept calls and have them go the mental health pathway instead of the police response pathway. We have 16 mobile teams covering 24/7. And like I was mentioning before, they have that incentive time to respond faster to law enforcement. Sergeant Wincy is going to talk to you about the various co-responder teams we have. And then we have our crisis facilities that are easy to access for law enforcement. And all of them with a drop-off time of 10 minutes or less. And then some various post-crisis follow-up programs. But to the officer on the street, it doesn't look like that pretty schematic with everything lined up. There's all these different choices. And that's where this concept of no wrong door comes in, where we're not expecting, even though the officers are pretty good at knowing like who needs to go where, but we don't expect that. If they bring someone somewhere, then we're not going to put that on, but the person really needs to be somewhere else. We're not going to put that on the officer and say, well, put that person back in your car and go on a wild goose chase. We're going to say, thank you, sir. May I have another? And then we will figure that out. We're not going to put the patient and the officer in the middle of that negotiating of where the patient needs to be. So sort of an example, and another important thing is the funding is these services that we have out here in Arizona are primarily financed via Medicaid, because this is at its heart, it's a healthcare response that we need to have. It's these emergencies are psychiatric emergencies, and so the healthcare system needs to have a response to that, just like we do for like heart attacks and strokes. So in Arizona, we have different geographical regions. I'm talking mostly about the South, and our Medicaid department braids funding from different sources. So Medicaid, the federal block grants from SAMHSA, as well as state and local funds. There's a crisis line item in the budget. And they braid all of that. They contract with a regional behavioral health authority that they put out for competitive bid for each region. And so ours in Arizona is Arizona, or in the South is Arizona Complete Health, which is part of Centene. And then they contract with all of us providers and then coordinate that system. And so the structure of it actually kind of supports having accountability and oversight, because there is kind of one benevolent overlord overseeing all the services to make sure that they function as a system. At the center is our crisis response center. The county built this with bond funds back in 2011. So the county owns the building. They lease it to the Behavioral Health Authority for $1 a year. It's like really awesome, cheap rent. And then the services that are financed via that Medicaid stream that I just described. So even though the county owns the building, the county's not paying for the services because it's a healthcare service. We serve about 12,000 adults, 2,400 kids per year. My organization's been running it since 2014, and it is the major law enforcement receiving center with no wrong doors. So we take everybody, regardless of acuity, how agitated, intoxicated. We like those people. We want those people. We think we can take better care of them. And we do that without using security. We've got a urgent care walk-in clinic for both the adults and the kids, where you can walk in, say you're new to town, need to be hooked up with services, or you missed an appointment, need a med refill. So we can handle that in a couple of hours. There's the 23-hour observation unit, which is really the heart of the operation, where we're taking those people who could go to a hospital if they were in an emergency room, but we think we can resolve their crisis and get most of them home the next day. And then for people who need to stay a little bit longer, we have a short-term subacute unit where people can stay for an additional 3 to 5 days. There's space for various co-located programs, some of these wraparound programs and things like that, the community programs to come in and be co-located and work with their individuals in crisis. And it's part of a cool campus that was built with the bond. The call center is in the building also, and then the bond also built, it's basically on the county hospital campus. And so the Banner University of Arizona Medical Center Emergency Department is right next to us. There's a breezeway that connects us. There's a 66-bed inpatient hospital that does most of the involuntary admissions for our community. And there's a mental health court right there as well that does the civil commitment as well as some criminal matters. When I was talking about that easy access for law enforcement, this is kind of an example of what that means is we treat them as a preferred customer. They've got their own entrance. They come through a gated sally port, so it's secure. They ring a buzzer. We measure the time it takes for us to respond and get them out of there. They also don't want to be walking around having to make copies and go to the bathroom and having our staff hassle them about taking their guns off. So they've got their own bathroom, they've got their own office, they've got refreshments. We have a coffee machine in there now. There's a Keurig, so donuts on National Donut Day. So, you know, we really want them to prefer to use us. In the observation unit, like I was saying, the purpose here is we're going to assume we're going to resolve the crisis. So we don't say, oh, you're really sick, we're going to put you on the list to go to the hospital. We say, oh, you know, you've got a lot going on. We're going to work to resolve that crisis. And only after the 23-hour period, if we still haven't been able to get that person stabilized, then we pursue sending them to the hospital or to our subacute. And we do that with the interdisciplinary team. We have 24/7 psychiatric coverage with peers with lived experience. We have nurses, behavioral health techs, social workers. And so we're working on, you know, interventions that include medication and detox, as well as groups and peer support. And then our crisis workers are on the phone with the families and the clinics trying to figure out what that person needs. Then how do we know how well we're doing? So we've, again, I was saying there's not any standards for crisis services. So we've worked on creating our own measure set, and I won't go through these in particular detail, but some of the most important ones are the ones that I've already kind of highlighted around. We want to do things in the least restrictive way. So, you know, we look at seclusion and restraint just like most behavioral health agencies do, but we also look at least restrictive in terms of, are they discharging to the community instead of the hospital? And even if they, and if they come in involuntary on, you know, on like an involuntary hold, are we able to engage with them and convert them back to voluntary status? And we're the largest, and we take the highly acute folks in our region, but we have a lot of rural areas as well. And so within our region, there's other agencies have smaller units that that are a little bit less acute, but about an hour and a half, like wherever you're at, the police are able to bring somebody somewhere. I'm going to hand this over to Jason then to talk about what our police are similarly taking a systemic approach rather than a program here and there. And so Jason can walk us through that.
Hello, thanks for having me. My name is Jason Winsky, and I'm the sergeant of the Tucson Police Department Mental Health Support Team. I'm going to speak a little bit about how our team works and interacts with all of the systems that you've heard about already today. This first slide here is just to show that everything that we do as a police department to interact with these systems really starts with training. So we have to make sure that our officers have the training to use all the tools and resources that we have in the community. So all of our officers receive mental health first aid. That comes in the academy, and that's the 8-hour course. We use the Memphis model voluntary CIT training, and we have several hundred officers on our police department that have received the CIT training. And then our specialized units like SWAT, hostage, the mental health support team that I supervise gets a ton of additional training on top of that. Next slide. So probably some of the most important things you need to know about our MISS team is one is we are dedicated and not designated. And that's a really important distinction for those of us, especially in law enforcement, because what that means is my team members are not in between the traffic accident and the burglary call. Mental health and resolving crisis and doing outreach is really all that they do. We use what we call a low and slow approach. So you can see from the picture there, we get out of our traditional uniforms. You can definitely still tell that's a police car, but we try and tame down the police car as much as we can. And we do really two basic things as a whole. One is we serve all of our involuntary civil commitment orders. So we call it court order treatment in Arizona. A lot of places call it AOT, but my team is responsible for serving the mental health court orders, the pickup orders. The other thing we do, which is really interesting, is we have detectives that are basically just what the slide says. They're weird stuff detectives. And that's really the proactive piece of our team. They're out there trying to investigate cases that would not traditionally be investigated by a police department to try and make preventative interventions. Next slide. So we started, like I talked about, with just mental health, and we've actually expanded our team now to 3 whole squads. The first is the mental health team that I just described. The second is our deflection program. So one of the things we're doing in Tucson is a true, really genuine deflection program. If people are caught with really any amount of personal type use drugs, they are taken to on-demand treatment. The charge is not held over their head at all. The charge is completely just dismissed and they go to on-demand treatment. Our newest, kind of latest and greatest program is our homeless outreach, which is just a pure outreach team that goes out and engages with homeless people and tries to get them into a housing first program that we have here. We're very lucky to work with Pima County and their housing first program. All 3 of these programs involve corresponders. Some are clinicians, some are peers, some are navigators, but they all use a corresponder model. Next slide. And this slide just shows that we have some really good data and some really good outcomes here in Tucson. The long story short is the more people that we take to treatment, the better outcomes that we have and the less people that get taken to jail. Next slide. This, again, is just some more data that says that the more people we take to treatment, the less justice involvement we have. And there's also a question that we get a lot is, what is the financial impact of that? Well, we've been able to greatly reduce our SWAT team callouts with the use of our mental health support team. And each one of those costs on average $15,000. I'll just end here by saying that really nothing that we do here, I really want to reiterate what Dr. Balfour said earlier. Without a viable, on-demand, 24/7, no wrong door crisis center, like you heard about, our team just really wouldn't work. Without that viable option to take someone other than the jail, really a lot of what we do just wouldn't work. So thanks.
Yeah, and speaking of like making business cases, this is Maricopa County, which is Phoenix, which is to the north of us, and so it's a very similar model, but still different because it's got a different behavioral health authority. But there's 3 main crisis centers in that area, and they've been able to do an analysis of all the police time of waiting in ERs and things like that. That it saves 37 FTE of police officers. So that's kind of another way to make the business case, and also saving the hospital emergency room costs and things like that. Let's see, this is from one of our, I didn't realize it was all animated like that. I borrowed this slide from one of those other agencies that's in Phoenix that also has sites across the country. And we were talking about equity. And so the field is now starting to dig into that. And so they're comparing the population or the percentage of their who they're serving that are African-American versus in the general population. And so you can see that the crisis, the people served in the crisis facilities, it's a higher percentage of African-Americans than in the general population in those areas, which shows that perhaps it may be having an impact on the disparity of jail utilization, but it's something that we need to look at and need to start looking at more. And so that's one of the recommendations in our Cops, Clinicians Are Both policy paper, is that with the metrics and studies and outcomes that we need to start to dig into this issue and learn more about it. And so at the last, we're going to blow through and we'll put these slides up to figure out how we're supposed to put it on the Huba app, but we will do it. But just some recent things going on and some tools that you can use. There's been a lot of progress towards national standards. You may have heard of Crisis Now, which defines kind of what the essential services are. This is from back in 2016, 2017, of having the crisis line and the mobile teams and a crisis stabilization unit. Since then, SAMHSA has updated it this last year. That's the crisis services meeting needs, saving lives. That has more up-to-date and more info and toolkits around implementation. And as part of that is our policy paper, Cops, Clinicians Are Both, which is most of what's in this presentation. But there's a standalone version of it at the link below. Crisis Now, which has been supported by the National Association of State Mental Health Program Directors and others, has a really nice website with lots of tools on it. There's reports and infographics and various tools. They have a blog that has up-to-date news and interviews, and so that's a great place, for resources. Recently, meaning like last week, the National Council for Behavioral Health, along with the Group for the Advancement of Psychiatry, put out this 200-page we call roadmap to the ideal crisis system, and I'll disclose I'm one of the authors of that, where it's really meant to be a blueprint for then how do you not just build the services, but the structure, the oversight, the financing, for how do you start to build a crisis center or a crisis system with measurable standards and self-assessments to see where you're at and where you need to go. And the link for that is there as well. There are 988 is, Matt mentioned that there's the National 988 Act, the Suicide Hotline Designation Act that was signed last year, that designates 988 as the hotline, and it's supposed to be implemented next year. So lots of states then have started with their own 988 legislation to build that out, and they're realizing that if you just have a crisis hotline that everyone can call, it needs to connect to something. So in some of these states, the 988 legislation is leading to legislation that funds more of the stuff that we were just talking about. So it's a good opportunity for crisis services. There is a learning community. There's a weekly call that's like actually was right before this thing. If you email either me or one of us, or David Covington, who runs that, you can be added to the call list. I think this is then the American Rescue Plan Act included the Cahoots Act, was sort of rolled into it, which uses Medicaid as a way to incentivize states to expand mobile crisis teams and co-responder teams. And they do that by saying, hey, states, if you create a mobile crisis team, we will have the feds put in a much higher rate of federal match than they usually do to incentivize them, because then it's basically they get it as kind of at a bargain rate. The block grants to SAMHSA were increased, which may include a set aside for states to expand their crisis services. And there's more funding for the certified community behavioral health centers, which are federally funded centers like FQHCs and for behavioral health, and they have to respond. They have to provide crisis services as well. But you look at this and who's missing? Like, just want to make the point that private insurance doesn't pay for hardly any of this crisis stuff, and Medicare doesn't pay for hardly any of this crisis stuff. And so, that's an advocacy point. And Matt can talk about these.
Yeah, I think maybe these could go to the slides. Can we maybe go to Aisha's slides just to hear from her about the learning networks in our last couple of minutes? Cool.
Yeah. Sure, thanks, Matt. So just really quickly, all of this information obviously will be on the slides, but there's also a lot that for those of you who are on the phone are interested in actually implementing, it's going to be a lot to digest. And so there's the Council State Government's Justice Center, in partnership or supported by the Bureau of Justice Assistance, has identified 10 communities across the country, including Tucson, Arizona, that have really strong best practices at the intersection of behavioral health and law enforcement. And those communities are available to provide peer-to-peer support, to host site visits, to jump on phone calls, to provide procedures and manuals, and otherwise to support other jurisdictions who are interested in building up a comprehensive crisis system and crisis response. So if you are interested in that, please do reach out. You can click on that link to get the overall framework for some of this work. And then the next slide, in addition to the law enforcement mental health learning sites, there's free technical assistance, one-on-one calls, emails, coaching available to jurisdictions, law enforcement, behavioral health providers, anyone who's really interested in developing these programs. And you can reach that through that link there. We also connect you to the law enforcement mental health learning sites and to a range of partners who are doing this work. So as you're thinking about how to implement, if you have questions, please feel free to reach out to those resources, or of course to anyone on this call, but those resources are really available to the entire community. And then last slide, one other thing that we have available is the Stepping Up initiative, which focuses a little bit more squarely on reducing jail incarceration for people with behavioral health conditions, but that's another learning network that has over 20 innovator counties who have done good work to significantly reduce incarceration for this population, who are available as resources to other counties that are interested in doing this work. So thank you so much. And please do reach out if you have any questions.
Great.
Okay,
Thanks
I
everyone for
think,
coming.
yeah, I don't know if, does this go to 11 or are we like technically